Hello, good morning, everyone. Are we all comfortable? Sitting well? I think it's time we should start the session. So, thank you for joining us today for this session on barriers to birth registration and opportunities to improvement. My name is Subhashri Das. I am from Vital Strategies. I will be moderating this session. We have a great lineup of speakers today. As you can see, we have three speakers here with us, and we have one recorded presentation, which will be at the end. So we'll begin with Mr. Nirmala Kumar Sharma from Nepal, who will present on urban-rural disparities in birth registration in Nepal, administrative barriers and perceptions. Mr. Sharma is a technology and systems professional with experience in civil registration and social security systems. His work focuses on strengthening digital CRVS systems, particularly improving birth registration coverage and timeliness through data-driven research and system integration. He has also been actively involved in linking digital transformation with public service delivery in CRVS. Welcome, Mr. Sharma. This will be followed by Dr. Richard Kabua Muamba, who will present on the determinants of timeliness of birth registration in Lesotho from 2018 to 2022. Dr. Kabua is a Mosotho medical doctor. He obtained his medical degree from the University of Lubumbashi in the Democratic Republic of Congo, a diploma in clinical management of TB and HIV from the University of Cape Town, and a master's degree in clinical epidemiology from the University of Pretoria in South Africa. He is currently practices at Senakatana TB HIV clinic and also serves as cancer registrar at the Senakatana Oncology, where he contributes to the clinic in Lesotho. In addition to his clinical responsibilities, Dr. Kabua is a CRVS mentor with the United Nations Economic Commission for Africa, where he contributes to the strengthening of the civil registration and vital statistics systems in Lesotho. His research interests include TB, HIV treatment outcome, cancer surveillance, and CRVS strengthening, with a particular focus on improving the completeness and quality of birth, death, and cause of death data. Thank you, Mr. Richard, for joining us today. Next, we have Dr. Murtaza Haider from the Water and Power Development Authority, WAPDA, Pakistan, who will present on the strengthening birth and death registration insights from WAPDA hospitals and healthcare providers. Dr. Haider is working as Director, National Institute of Rehabilitation Medicine. He previously worked as the Assistant Chief, Ministry of Planning and Development. He also worked as a Senior Medical Officer at WAPDA. Dr. Haider is a staff member at IOM and WHO. His qualifications include MBBS, LLB, PGD in Medical Entomology, PCG Humanitarian Health Program Management, and MS in Project Management. He is currently involved in the CART initiative. Welcome, Dr. Haider. Finally, we have Dr. Murshida Sharmin, who will be joining us online, and Dr. Rafiul Hassan from Bangladesh, who will present on community-driven approaches to CRVS improvement, evidence from Guniagar, South Indian, Bangladesh. Dr. Sharmin is a Joint Secretary at the Cabinet Division of Bangladesh, working in the Civil Registration and Social Security branch, with extensive experience in strengthening CRVS systems, particularly in improving service delivery in rural areas. She is joined by Dr. Rafiul Hassan from Director General Health Services, who contributes strengthening CRVS systems through public health programs and implementation. Mr. Sharmin is online and the presentation will be played. It is pre-recorded, and Dr. Rafiul is here with us in the room. If you have any questions, Dr. Rafiul will present behalf of that. Okay, now we have some housekeeping rule. Each speaker will present about 10 minutes. If time permits, we will take few questions, around 5 minutes. And after each presentation, or else I encourage you to note down your questions and we will address them during the dedicated question answer session at the end. So now we have a great group of presenters. So let's get started. I would like to invite Mr. Sharma to present his findings. So, Mr. Sharma, over to you. Thank you.
Good morning, respected moderator and participants. My name is Nirmal Kumar Sharma. Today, I will present my research topic on urban-rural disparities in birth registration in Nepal. I would like to thank all of my supervisors and and supporters who are directly involved in this research. Introduction. A legal identity is a fundamental human rights and it is essential for health, education, and social protection. Coverage of birth registration in Nepal is increased, but timeliness remains critically low. We observe an urban paradox as in graph like NDHS, census, and MICS. This study try to identify why this happens even if even in the better infrastructure and social better infrastructure and access in the urban area, but registration is lower. Methods. This research employ a mixed method study. First, quantitative data were collected and analyzed using logistic regressions. Then qualitative data collected using key informant interview and focus group discussions. And the combination of both is more accurate to understand the statistical pattern from the quantitative analysis and real life experience from the qualitative analysis. Results. Urban advantage in access does not translate into the better registrations. That is, urban registration is slightly low. Less than 30% of the children are registered within 45 days, and most of the registration occur after 1 year. During logistic regression, we found that administrative burdens, that is, multiple visits in war office and complex documentation get a strongest negative predictor. Similarly, in urban, similarly in a rural area, the distance and distance of war office predict a strongest predictor. Why does the urban paradox exist? In urban area, there is high caseload and congestions, system instability, complex verification process. While in rural context, there is more than 3 kilometer distance is found as a strong predictor. Then motivation drives the different behaviors for the registration. In urban context, the mindset is a register when needed paradigm, while in rural context, linked to the child benefit, social protection benefit which enable the higher registrations. Similarly, the digital systems also will not play an effective role. In urban area, uh, physical presence of the informant is mandatory, so digital system is not work as a predictor. Discussions. Urban paradox confirmed because urban children are less likely to be registered on time, which shows that access alone is not sufficient. And administrative burden also found as the core barrier. Reported visits and complex procedures delay registration and stronger determinants across all models. Different context, like in urban, system complexity, congestion, and register when needed mindset plays a role, while in rural area, distance, travel cost, and incentive-driven behavior play a role as a barriers. Then, when administrative burden is controlled, urban-rural difference will disappear, and inequality is driven by system, not a location. Policy implications in urban, reduce administrative burden will increase the registration of timeliness, simplify procedures, reduce documentation requirement, and minimize repeated visits, and enable registration at place of occurrence will increase the birth registration. Similarly, in rural access, mobile registration and outreach will play the reduction, increasing the birth registrations. Also, system-wide reform for integrate with health and education system, move to in digital registration, and reduce reliance on in-person verification in ward office will play the vital role. Recommendation: make registration process simple with less documentation and fewer visits. Allow registration where the child is born, and bring service closer in rural area. Also, make digital system fully functional end-to-end and link register with hospital and social benefit. For the further research, study urban migrant and its gaps, study hospital-based and automatic registration pilot will improve the digital systems. Thank you. I welcome your questions and feedback.
Thank you, Mr. Nirmal Kumar Sharma, for the great presentation. We have 2 minutes to 3 minutes of time. Do you have any questions now? Or else we can have question and answer at the end. Any questions? Would you like to ask? Okay. Do you have a microphone? Okay.
Yeah, thank you. Thank you, Mr. Sharma. I think, it's really interesting to see that the registration is less in urban as compared to rural. I mean, it's very interesting finding because in most of the countries, if you see its urban registration is better because most of the institutional deliveries across the world, takes place in urban areas, is it? And all are registered. So maybe I could not understand it properly that what is the single determining factor because of which it's not working, because you have mentioned all the pros and cons, advantages and disadvantages in both areas, but I could not find a single key factor which determines because of which rural registration is high. Thank you.
Before you speak, so please introduce yourself and where are you from?
I'm sorry, I'm Ritu Kumar Mishra, working in Malawi UNDP.
Thank you.
As per these findings, single variables is satisfied during the logistic regressions. there may be other factor. We found that during the qualitative analysis, like multiple visits, actually the migrant people are not allowed to register in place of occurrence. These factors were not analyzed, statistical analysis. So during the statistical analysis, we found multiple variable like economics, age, and then sex, similarly education, but these are not satisfied.
Okay, thank you, Mr. Sharma. I can give you one example. Bangladesh is also one of the countries where rural registrations are more than urban areas. Because they have a very strong system in rural areas where village police collects the information, helps the family to register. But in urban areas, as Mr. Sharma mentioned, many families are asked to visit their permanent house to register the event. And also there are some other things like they have to give us house tax bills so that they can register the child. So yeah, I mean, Nepal is one country and Bangladesh is another country. This might be helpful for you. Thank you. Okay, so now we'll have more question and answer at the end. I would like to invite Dr. Richard Kabua for your presentation. Over to you. Sorry for this.
Thank you. So good morning once again. I'm so happy to be here to present with you, and thank you, Dashet Nicolas, for giving the opportunity to present. I will present on the timelines of registration in the vital statistics system in Lesotho from 2018 to 22. So before, I would like first to say a word of thanks to my supervisor, Lilian, who is with me here, William and Alan and Pamela for supporting me throughout my research. A special thanks went to ESCAP and UNECA and Vital Strategy, Bloomberg Philanthropy for supporting the CAT program. So my presentation will cover the following section: 1, introduction; 2, aim and objective, methodology, result, conclusion, and policy recommendation. So from this slide, I would like to first of all to give you a short picture of what's happening in the world in terms of birth registration. You can see that it is estimated that worldwide 166 million children under the age of 5 are formally not registered, with another 237 million still children under the age of 5 without a birth certificate. And in sub-Saharan Africa, the situation is still the same. We only have 46% of children under the age of 5 who are registered. In Lesotho, birth registration completeness increased from 21% in 2019 to 74% in 2021 before declining to 61 and in 2023. So the aim of my study was to determine factors associated with late registration in the CRVS system in Lesotho from 2018-22 as a specific objective to identify the factor, to identify socio-demographic and institutional factor associated with late registration still in the CRVS system 2018 to 2022. So to achieve this objective, we have conducted a retrospective study design with data obtained for the CRVS system for the period 2018 to 2022. And the outcome variable, we have current registration for both who are registered during 1 year and late registration for both who are registered after 1 year, meaning 365 days. As a possible variable, we have sex, years of the registration, place of birth, districts of registration, mother's marital status, and mother's age. For statistical analysis, we have used a descriptive statistic to try to describe the trend of birth registration in the country, and logistic regression to find this possible factor associated with late registration in the CRVS system. So here is the main key finding. We have found that, first of all, there was slightly male who were registered than female, but the difference was not statistically different. Secondly, birth registration was declined in 2019, and it even went further in 2020. So as a factor associated with late registration, the high order of late registration was found among children born at home in the district of outside of the district where the child was born, mother younger than 15 and older than 45, customary marriage, and mother who were divorcee or widows. So apart from that, we also found that some weakness in our system. So there was so many data outliers, especially the mother's age, if you can see 15 years, and also missing variable from some records. So for this one, you can see this. It shows three things. The trend, first of all, of birth. You can see in 2018, it was at 50 something, then it's declined and it will go further. And in 2021, it went up and declined again. So that is just the number of births that were registered. So secondly, this shows again the children was registered late. You can see it in 2018, it was at 94.6, 91.3, 91.4, meaning between 2018 to 2020, late registration was almost 90%. So from 2021 to 2022, it went to 86 and 73. So regarding birth that was registered within 1 year, it was 5.4, 8.7 in 2019, 8.6, and we try to go up to 13.9 and 26.2. In conclusion, we have realized that birth registration in our system throughout this study, it was late. There was late registration. The factor that was associated with late registration, there was children born at home, mother younger than 15, older than 45, children from customary married, divorced and widows, mothers, and when the registration took place outside the district of birth. So based on the funding, we come up with 4 recommendations. One is to strengthen the CRVS system, to strengthen the collaboration between all key stakeholders involved in CRVS activity, such as the Ministry of Health, Ministry of Education, and the Bureau of Statistics. This will help to increase awareness and uptake of birth registration. Second recommendation, to implement public awareness campaign to educate family on the benefit of early registration. The third one is to promote community engagement, to try to work with community leader, chief, village chief, the priest, the pastor, so that they can try to encourage and support timely birth registration within the community, including the village of Rigaka. The last one is to monitor, to strengthen monitoring and evaluation, because you have realized that there was also a problem with that based on data of poor quality. Then we say we recommend implement regular monitoring system to track birth registration rates and to identify barrier early. And thank you so much.
Thank you, Dr. Kabua, for presenting on a very important topic, timely registration and late registration, and why it is important. Do you have any questions from the audience? You have? Sure, please go ahead.
Yeah, maybe a simple one. Looking at the graph, was there an intervention that happened maybe after 2020? Because I can see the graph of the overall birth registration is a little bit increased. What happened in 2021?
Okay. I think in 2019, I think.
No, I mean the overall birth, right? Number of births registered, the overall.
Yes.
In 2021, there was an increase, a sharp of increase. What happened? Were then some interventions?
Yes. I think 2019 there was COVID, everything was down. Then after a few months after COVID, we got so many support from Vital Strategy and ECA So that have helped to increase that sharp increasement, especially from the donor, WHO, Vitalsat, especially Vital Strategy with some grant that we got, and it's helped to go up again. And down, why down? Because we also have some registrar, people, CR registrar are working part-time. Sometimes when the contract ends, things, they sit at home and the support that we got from Vital Surgery with some donor, it was for 1 year, 2 years, things like this.
Were there any recommendation to avoid the decrease? Because if in 2022 was the decrease, aren't you afraid that maybe it will continue decreasing over time?
So that's why we have suggested that strong collaboration between key stakeholders involving CRVS activity, especially ELF and the Bureau of Statistics and the other ministry. Let me tell you the example of ELF. ELF, they don't budget related to CRVS activity. You see, CRVS activity remain a little bit behind. Even when you go to the hospital, you ask about registration, they will say, no, it is not my job description. So we have recommend that, and like before we travel, there was a MOU that was signed between Minister of Health and Home Affairs, including some key stakeholder, so that work together in terms of CRVS registration.
Thank you. Maybe I forgot to present myself. My name is Jean-Claude. I think I work with this here. Thank you.
Okay, great. Thank you so much. We'll have more questions at the end. Sorry for this. I would now invite Dr. Murtaza Haider. Yeah.
Thank you very much, Subhashri. Thank you, Nicholas, my fellow participants, and distinguished guests and delegates from all over the world present in the room and the online. Very warm welcome and good afternoon. My research topic is strengthening birth and death registration insights from WAPDA hospitals, healthcare providers. I would acknowledge the support from the host organization and my mentor John, and special thanks to SCAP, especially mentioning Petra and Tanya for their proofreading and giving the insight on my topic. And I'm also grateful to my parents and my family. A strong CRV system is fundamental requirement for the strong and developed economy. And to ignite the engine of economy, all segments of the society must act together, and social sector is not an exception. There is strong evidence that weak performance in CRV system is likely to become weak because of so many other things like a lack of information technology, lack of logistic support, and it was observed in public sector hospitals in Pakistan. If the current birth registration in Pakistan under 5 years of children is 34 to 42%, and there are almost about 10 million children who are missed out for the birth registration. Imagine if parallel health system is not chipping in, then this number would go increase. Studies suggested that if parallel health system is performing more proactive role in civil registration, this may add to improve national database economy and the national database repository. So WAPDA health system, they have a parallel health system, which is at par with the mainstream health system. They have a network of 120 hospitals. So it was very interesting, and it was a gap that what parallel health system is contributing, whether or not they are performing to contribute and support the CRV system or not. This is the gap, and we did the research for this purpose. We adopted a mixed method approach, a strategy, in-depth interviews with the specialist cadre, and then focus group discussion with the nursing cadre, and then quantitative surveys from the administrative cadre and the medical officers. This was strategy, and we step by step we took all these questionnaires. And then what was the purpose? The purpose was to study, examine awareness of the CRVS and legal framework, data transmission, and registration process and stakeholder linkages. So these measures allowed assessment of the current practices and identification of the gaps in CRVS registration. Interestingly, few comments came from all the participants. I would mention few that WAPDA health facilities are not implementing CRVS practices at their premises. There is no collaboration program. There is lack of training. Some would suggest that the registration, for example, death registration or birth registration is taking place in only hard form in registers only, and there is no digitalization, and there is no mechanism of developing linkages between the external environment, and no information is going out of the system. The sorry. Uh, for the quantitative analysis we did from the general duty medical officer, and it was observed that birth registration, they were aware of the birth registration processes, but they're registering it on the registers only. There is a taking place in writing on paper only. There is no other digital method was adopted. It was all paper based. For the linkages with the external stakeholders, they have stated that maybe all the stakeholders outside the system are very important to be contributed, and information should be shared with all them. And then they suggested that focal person should be nominated for each and every facility. Uh, then they were aware of the cause of death, but unfortunately, very few knew about the ICD coding or WHO classification. So in the end, it was that awareness of CRVS initiative was lacking. Reporting flow is limited due to the lack of designated focal person. Death data is recorded only in registers. Participants see digital registration as urgent and necessary, and they are willing to support the CRVS initiatives, but they suggested that there should be clear administrative responsibilities should be on documents. So the recommendation is that after we conclude all these things, then there should be a developed training program for health professionals, and there should be logistic support provided to professionals to chip in their part for the CRV system, and then international code of classification should be implemented. And they suggested very interestingly that maybe mobile application should be there and computer-based application should be there to bring back the missing part, which is parallel health system, into the picture and into the mainstream CRV system. Thank you.
Great presentation, Dr. Murtaza. Do you have any questions now? Okay. I have a couple of questions we can discuss during the question and answer session. Now, I would like to invite Dr. Mushida Sharmin. The presentation is pre-recorded, so we'll play it.
Good morning, good afternoon, good evening. Esteemed colleagues and distinguished guests, I am Mushida Sharmin, lead author and Joint Secretary for the Civil Registration and Social Security branch of the Cabinet Division, Bangladesh. Today, I am honored to present our research paper titled Community-Driven Approaches to CRVS Improvement, Evidence from a quasi-experimental study in Gunaighar, South Indian, Bangladesh. At the beginning, I would like to express my sincere gratitude to my co-authors, Mr. Rafiul Hassan, Nazrul Islam, Moinuddin, and Mohammad Khalid Hassan, whose dedication made this study possible. I also want to acknowledge the Union Parishad Chairman, teachers, religious leaders, and our tireless volunteers for their great contributions. Special thanks to Vital Strategies for their unwavering support throughout the completion of this research work. We know that CRVS systems are critical because it provides the legal identity necessary for citizens to access health, education, and social protection. While we strive towards SDG target 16.9, legal identity for all, our rural populations still face significant barriers to timely registration. This study evaluates a community-centric model designed to bridge that gap. We conducted a quasi-experimental study from 2021 to 2025 in Gunaighor South Union, Kumilla. This area has a population of approximately 21,768 people. Starting in 2022, we introduced several interventions. There, conducting routine household visits to identify unregistered births and deaths, launching community awareness campaign to explain the legal and social benefits of CRVS, facilitating mobile registration services to bring the office to the doorsteps of the citizen. Crucially, this was a multi-sectoral effort. We coordinated closely with local government, health workers, educators, and non-governmental organizations to ensure no one was left behind. Our data was cross-referenced with Union Parishad records, census data, and direct household enumeration to ensure maximum accuracy. In this graph, as shown here, the number of people without birth registration dropped dramatically from around 8,689 in 2021 to just 275 in 2025. This indicates that the intervention was highly effective in reducing the backlog. We observed a steady increase in birth registration over time in this figure. Timely registration improved and completeness exceeded 100%, which indicates that previously unregistered cases were successfully identified and recorded. Delayed registration also declined. This graph shows death registration also improved over time, with increases in both volume and timeliness. However, the improvements were less consistent compared to birth registration, likely due to cultural and reporting challenges. Let us look at the evidence when we compare the pre-intervention phase to the post-intervention phase. The results are striking. Prior to our intervention, the average number of birth registration per month was 118.8. Following the introduction of the volunteer model, this rose to 181. More importantly, we looked at timely registration, birth registered shortly after they occur. Timely registration nearly doubled, increasing from an average of 16.8 to 30.1 2 per month. If we look at the completeness of birth registration within 1 year, the improvement is even more profound. Pre-intervention completeness stood at just 45.9%, and in post-intervention completeness reached 101.8%. You may note that the figure exceeds 100%. This is a direct result of our volunteers successfully clearing a massive backlog of previously unregistered children while simultaneously capturing current births. The delayed registration average also increased from 97.7 to 131.9, showing that household visits were effective in identifying children who had been missed by the traditional system for years. On the other hand, death registration is historically more challenging to improve than birth registration due to cultural sensitivities and a perceived lack of immediate benefit for the family. However, our model showed progress here as well. The average total number of deaths registered per month rose from 7.3 in the pre-intervention phase to 18.1 post-intervention. We saw a similar upward trend in timely death registration, which increased from 4 to 7.1 per month. When measuring completeness of death registration within 1 year, we started at a baseline of 47.1%. In post-intervention, this increased to 89%. While this is a remarkable improvement, it highlights that death registration still faces more barriers than birth registration. The increase in delayed death registration from 1.7 to 6.8 indicates that many families only register a death when prompted by a volunteer or when they require a certificate for legal or inheritance purpose. This underscores the necessity of the proactive notification approach we have implemented. Discussion is, why was the community-driven approach so successful? There are four primary drivers. First, the volunteer-led household visits removed the information gap. Many families simply did not know how or why they should register. Second, the mobile registration services addressed physical and financial barriers by reducing travel costs and simplifying documentation. We made the system accessible to the most vulnerable. Third, multi-sector collaboration was essential. By involving religious leaders and teachers, we integrated CRVS into the daily life of the community. When a teacher asks for a birth certificate at enrollment, or a religious leader mentions registration during a funeral, it reinforces the social contract. Finally, this model helped clear backlog. This model demonstrates that community engagement can strengthen CRVS systems in rural settings. In rural settings, many registration events are missed until a systematic enumeration like the one we performed brings them into the official record. We have proven that community engagement is not just a nice to have, it is a powerful strategy for strengthening CRVS systems in low and middle income countries. In conclusion, the evidence from Gunaighar South is clear. Community-driven intervention improve both the completeness and timeliness of vital event registration. To sustain and expand these gains, we recommended that we must institutionalize periodic volunteer-driven notifications within the Union Parishad structure to sustain these gains and prevent future backlogs. Strengthening multi-sector collaboration, we must continue to expand community awareness so that citizens perceive registration as a right and a necessity rather than a hurdle. Continuing mobile registration services, and based on these results, we believe this model is ready to be scaled up across the remaining 4,500 unions in Bangladesh. By empowering local communities, we are not just collecting data, we are ensuring that every citizen is counted and every life matters. Thank you for your time and attention. Thank you all.
Okay, so I think we are at the end of the presentation session. All our presenters have now presented. So thank you all of you for this, for such interesting presentation. Now we would open up it for question and answer. So if you have any questions, I know Rafiul, you had one question. Even I have couple of questions, and if the audience have any questions, please go ahead. The uh, who have joined online, I would request, if you have any questions, please write your name and organization you are from and your question so that we can read it loud for everybody. Thank you, everyone. Rafael, you want to go ahead?
I am Mohammed Rafiul Hassan. I am from Bangladesh. I work at the Ministry of Health and Family Welfare. And particularly, my question is to Richard that you showed that the death registration drastically decreased in 2019 compared with 2018. The thing is that COVID started in the December of 2019 in China, and I don't know when it was identified in your country. So, what, as far we know, the pandemic was declared in the March of 2020. 2020. So, what was the reason or what was the factor that decreased the number of registration? Because this is usually unnatural. That's why I want to know. Thank you.
Thank you, Rafael. Before around 2018, 2017, the country faced some challenge different challenge. The first one I can say we challenge with human resource. Most of the CR officer, civil register officer, they were working on the contract, basis on the contract. And it was basically donor funded. So when the contract is end, um, work stop, it's go slowly. So even those who are still working under the government, still under contract, it's still a challenge because based on the terrain of Lesotho, the Kingdom of Lesotho, there are some area which is difficult to access. So the Minister of Health have made, the Minister of Foreign Affairs have make some strategy to put CR officer in all of those areas. So and the majority of them they're working under contract. When the contract ends, it went down. So that's one of the reasons that there was also a decline in that period. Yes.
Thank you so much. Thank you.
Okay, great. Yeah, please go ahead. Please introduce yourself and to whom you want to ask the question. Thank you.
Yeah, thank you. This is Stephen Robert Kasumba from Uganda. I work with the National Identification and Registration Authority in the entity which is concerned with CRVS. My concern is mainly about NAPA. There are some interesting scenarios where you say digital system exists, but not effective. I am just wondering, is it because of the digital divide? Again, you have said inequality is driven by system, not location. And you conclude say by saying that rural performs better than urban. So it is really a paradox. I just need some more explanation on that to see whether really rural has more infrastructure as compared to the urban. Then in Lesotho, of course, Lesotho, I don't know. My colleague from South Africa, he said 46% of your population is still facing of birth is not registered. It's registered at only 46%, which is almost the same as in our country, Uganda. So I was interested very much in seeing the contribution of this research to the existing inefficiencies within our countries. I think it didn't come out well, but we gave a number of recommendations. You can just expound on that briefly. Then lastly, on Bangladesh, I can see, of course, she's not here, but oh, yeah.
So
the research is a bit wide, birth, registration, death registration. And you know, under death registration, there are a number of issues you have to look at. It is a bit complex, especially when it comes birth registration, death registration. I am just wondering whether the research was in a position to actually bring out those issues, especially in regard to the cause of death and others, which are a bit complex, and whether they really add to the existing knowledge in this area. Thank you.
thank you so much. Okay, we would first answer the questions, then we'll go to you. Thank you. So, Mr. Sharma, would you like to?
Interesting. In Nepal, I have studied two provinces, Bagmati and Lumbini provinces, where 100% ward offices, local registrar offices using online systems. While still delay registration means there is one things that even if the online systems, all informant should present in ward office to register the certificate. Only they can fill the form and submit the document, but they can't receive the certificate from the ward office or directly from home. That's the main reason that digital system does not work for the peoples. That is only for the officials and administrative purpose, not for the people.
Okay, thank you, Mr. Sharma. Yeah, I just would like to add one thing. So, digitalization is technology can solve your problems, right? You have to have your business processes as client centric, how client wants to register. So, technology is just a tool, and I think many of the countries are facing the same challenge, bringing big technologies, but not seeing the process from the client perspective. So I think that is one thing everybody should think about. Mr. Richard, would you like to?
Yes. Yes. For the first question that you have asked about the 46%, I think if I'm not wrong, you get it because it was the research was published from a journal in Africa in 2019, whereby it was saying that in sub-Saharan Africa there's only 46% of children under the age of 5 who are registered. It is not in Lesotho, in all sub-Saharan Africa. Yes. So about the I think the recommendation, the second question, can you come up again?
It was about the contribution. So how can we, because you have given about 4 of them,
Yes.
but of course the inefficiencies still exist within our system, within your system. So I wanted to know what you have done, what this research brings out in regard to the existing challenges in your country.
Okay. Before even before coming here to present, we got some support from Vital Strategy and ECA, whereby they were trying to put together all key stakeholders involved in CRVS activity, and we came up with a MOU so that we can collaborate. All the ministry can collaborate and try to increase to work in terms of increasing to work in terms of improve registration of vital events. So this one is a big milestone, I can say. Because why? Because now we can sit together different ministry. Before that, there was working in silo. No budget for CRVS activity like for Minister of Health. So this also contributes more. But now that we have this MOU and we have also established a CRVS national core team, I think things will improve. Yes.
Okay, thank you. We have last question to Rafiul. So he had another question to Rafiul. Rafiul, would you like to answer?
Yeah, thank you. Thank you for the question. Particularly, I just understood one thing that he was telling that whether we have addressed cause of death or not. Have you any other question regarding our study in Bangladesh?
Basically, my concern was that the research is very wide. I look at death registration itself as so wide with its own unique challenges. That is why I pointed out the issue of the cause of death. So I wanted some more explanation on how we went about it and how you can really have the two within the same paper. Thank you.
May I request the moderator? I couldn't understand the question. Can you explain the question, please?
Yeah. So he's saying the study was very wide. I mean, it is like clearing backlogs, and did you understand? So if I could reiterate it, so he wants to understand how how you are planning to. So can you please again? Sorry for this. It's difficult.
Yeah, I'm sorry if you don't get it properly, but basically, as you are saying,
Yeah.
the area is very wide.
Yes.
Death registration has its own unique issues,
Yeah.
which are very difficult to combine them with birth registration.
Okay. Okay. Understood. So he's asking the birth registration, the approach you followed, and for death registration, the approach you followed. Is it same? Because death registration is complicated and different, and birth registration is different, right?
Yeah, thank you. Thank you for the very nice question and addressing a important issue. The fact is that this was totally a community-driven approach. So our teams visited house to house. They asked the householders that has anyone here whose birth is not registered. that, and if there we found anyone whose birth wasn't registered, we brought them to the nearest mobile birth registration center, CRVS center, and we registered their births. Regarding death registration, in the same way, we asked the householders that has anyone in your family died in last 2 years? If there are last 3 years, if there were anyone who were died in last 3 years and his or her death was not registered, then we invited them and requested them to come to our mobile center of registration and we registered a death. And particularly there are some challenges, like particularly cause of death, because our system is not that much efficient to address all cause of death. Particularly, most of the death occurs at the house, at the household level. It doesn't occur at hospital. So medical cause of death is not assessed particularly. And there are some other issues in the interface also. I have another presentation the next after day tomorrow. I have addressed some things there also and in another study. And the one more thing, what maybe you are concerned, that we particularly focused on coverage and timeliness, not on cause of death, because we know that addressing cause of death is very tough, and that was not the objective of our intervention. So if you, I think I have cleared a little bit, and if you need to know more, I am ready to answer. Thank you.
Yeah, so okay. First, yeah, please go ahead.
Thank you very much. My name is Dipesh Resta. First of all, I would like to congratulate all the presenters for such a wonderful presentation. My question is for Mr. Nirmal. My question is, so your study shows a huge, not really huge, it shows the urban shortfall in case of birth registration. So there might be some factors that has been, affecting this kind of shortfall. So I would like to know what exactly are the factors that has been playing this role for such kind of shortfall in urban and rural areas regarding birth registration in Nepal. Thank you very much.
Thank you. Uh, uh, from this study, in urban area, there might be multiple visits for the documentation for actually migration registration, and they need citizenship certificate of the parents. This is the main factor that the urban area has shortfall for the birth registrations. Both documents, every parent does not have a citizenship and migration register at their end, but without this document, there is no registrations. This is the major issues.
Thank you.
Thank you, Mr. Sham. I think, okay. Yeah, please go ahead.
Thank you. Hi, my name is Sabeen Mulmi. I'm from Nationality for All. I'm also from Nepal. My first question is to our panelists from Nepal, Mr. Sharma, which is and a similar question to others as well, which is I'm mostly interested in the gender component. I was going through the paper as well, and I saw that in terms of the parents' gender, I think there's a big difference both in urban and more in urban, 64.6 in terms of female parent, and male was 35.24, and I think there's a difference in rural as well. So is it because more children are, I guess, living with mothers, or so if you can explain that, that would be really helpful. And make similar question to others as well. Did you also sort of in your, maybe if it was outside the scope of your research, that's fine, but if you also came across so certain sort of challenges in terms of registration of births of children who were living with single mothers, who didn't have fathers, or who were not living with their fathers, and that sort of created delay in the timeliness as well, or other sort of challenges as well.
Thank you.
Thank you. This is during the data collection. Most of the people who, most of the parents who is in home, that found that the mothers, this is a female. Actually, analysis is not a such part, either male or female. This is not studied that.
Yeah, please go ahead.
Thank you very much for asking this question. Actually, this was out of my research scope. But let me clarify one thing. When I was doing this research, because my research was, encompassing the healthcare professionals, responses only. So in my study, I was compelled to have respondents from the one single facility, regardless of their gender. All the employees who are employed as a specialist, who are the medical officers, who are nurses, and medical administrators. They were my respondents, regardless of it, because I have to take all in, except if somebody has declined voluntarily. So that was not my scope of the study.
Thank you, Dr. Heather.
Thank you. For us in Lesotho, in terms of gender, there were more children male who were registered compared to female, but the difference was not statistical difference. With male was at 50.1% and female at 49.9%. Not much difference. So in terms of your second question, in terms of factor associated with late registration, we found that children born from a widow, from divorcee and widow, they had a high hold of registration late than others category, other category.
Thank you. Before we go to more questions, I would like to ask one question to Dr. Heather, because we have asked so many questions to Nepal, Lesotho, Bangladesh. So, Dr. Heather, I would like to understand, you highlighted gaps in notification and reporting in the hospitals. So, how should we understand the role of hospitals can play in strengthening the CRVS systems more broadly? If you could.
Thank you for bringing up this question. A very important question. Actually, what I was suggesting in my research, that parallel health system should be contributing towards the mainstream health system. A lot have been done and a lot have been studied for the mainstream health system, but parallel health system are neglected behind. So in this case, if like I quoted the number that 10 million children are already missed. If the parallel health system is not contributing in, then this number would go on increasing. In this case, parallel health system should be supporting the initiative of the CRVS system, especially if I talk about the health sector, then the hospital-based birth and death registration should be taking place, from the hospitals. So in this study, I found out that because parallel health system, as I already said, that this is a neglected chunk of society. So no proper training was there, no proper registration system, digital registration system was there. Only the register, the hard copy of the registers were available in the hospitals, but they were, because they were not trained for this thing, from the either side, not only from the administration of the particular hospital, but also from the mainstream health system. They are not coming in to train them and to bring them on board. So this was the issue in my case. So and study really highlighted these issues, and similarly, after that, we were able to make these recommendations that should bridge the gap for both the ends.
Thank you, Dr. Heather. I could draw one very important point: the proactive registration of births and deaths occurring at the hospital. Like, hospitals should take the responsibility to declare the event so that families doesn't have to travel anywhere, and that event can be go to, if it's government hospital, they can declare behalf of the family. If it's a private hospital, the hospital can facilitate the event. So that's how hospitals should keep this proactive service to citizens, and not citizens, like everybody living in the country. Thank you so much for that. I think there are some questions. We'll go to you later, but would you like to ask from that team? No? You want to? Please go ahead.
Take my greeting. I am from Bangladesh. I am Hosnaira Parveen from Ministry of Health and Family Welfare. My question is Mr. Haidar. Is it representative? You did the work is in one hospital, the WABDA, am I right? And is it representative of all Pakistan or all the condition is my one question. And number two question, I evaluate the surveillance of medical causes of death at my academic work from 2020 to 2024. I saw that there is a difference between the medical certification of cause of death and medical certificate. So that is the different things. And in my Bangladesh, there is no collaboration, a little bit collaboration between it. But how can you take this in Pakistan? What is the collaboration between the medical causes of death and medical certification? Thank you.
Thank you again for asking a very interesting question. Actually, in this case, first part of the question was regarding the registration. Yeah, representative of the sample. Actually, because of time constraint and logistic constraints, I was inclined to do only one facility. But I can say with confidence that all the 120 health facilities within the same organization, that WABDA, they have similar situation. Why? Because administration has not issued any administrative note to any of the facilities. So obviously they are not following the instruction from the top administration. It means that they're obviously not trained for any kind of such activities. Neither one of the slide was mentioning that they were aware of the international regulations, but they were not aware of the classification because they were not trained for it, and they were not asked to perform these activities. So the point is that we are in our country, for the classification of disease and ICD coding, we are very far behind, because at the moment we are struggling to even support the health systems to come up with the digitalization of the at least something, as Subhashri was also mentioning, to start reporting it. We are far behind it. So classification of disease will be occurring or will be happening when we advance that initial stages. So, and we are not really hoping it will be very ambitious, short-term target. But yes, obviously, it is in our hindsight that we will follow it. But at the moment, we are struggling to get those facilities which are not chipping in for the CRVS activities, to bring them on board and train all the professionals that this is their professional and responsibility for the society, that all these things should be registered and they should be go into the main database of the country. I hope I answer you.
Yeah,
Thank you.
I also added with Dr. Rafi, in my Bangladesh, there have a post in the rural area that is Bengali name is Chowkidar. He starts home to home, door to door. In last 3 years, what is happened? But it is a nice for Bangladesh CRBS system strengthening. But we are not aware about the urban area. But door to door search this is so much difficult for some rural issue. Thank you.
Thank you so much. Mira, you want to go ahead? Thank you.
Thank you very much, and thank you to all the presenters for such nice sessions. Just speaking to the slide that is up there, and this is open to any of the speakers. A lot of the research has generated very important evidence in terms of, what are the determining factors, in terms of timeliness, in terms of accuracy, and in terms of effectiveness of certain interventions. Now, I just want to hear from you about what next, like how successful have you been in bringing these recommendations to action, right? Whether that's reallocation of services, whether one of the speakers said a new system of that kind of declaration was established. So if you could just share in terms of what are some of the things that you've done to actually translate this evidence that you've generated into action, maybe it'll benefit the others in the room as well. Thank you.
Thank you. In case of Nepal, to timeliness registration and increase the birth registration coverage also, Nepal has planned to integrate the national ID to the birth registration system, which is started piloting already, and now generated national ID during the birth registration systems. Another one is from the health facilities, one district is piloted directly registration from the birth facility. These are the main strategy to overcome these barriers. Thank you.
Thank you for asking this question. Actually, you pointed out that the very important outcome of this research is that policy brief or policy recommendation. In my case, as I said, that administration is not on board. So my first thing is that I will go the head of the organization, that is Chairman WABDA, and tell him that 10 million children are already missed out for the birth registration, and if WABDA network of the WABDA is not chipping in, it will go on increasing the number. And if the birth registration is as low as 34 to 42%, and again the parallel health system is not coming for supporting it, then again it will be worse condition. So if to improve the health system and the health policy at the national level, all the public sector institutions should chip in. So my policy brief would be very clear to the head of the organization, that at least issue some administrative directive to start doing these things. And once I'm not hoping for very short interval or short future, but maybe slowly and gradually we can gain on these things, and ultimately we'll reach the goal.
Thank you, Ma, for the question. For the case of Lesotho, and I think 3 months ago, with my colleague from Lesotho, she is going to present, I think tomorrow, we have presented the preliminary result of our both study to our director, the director of National Identity and Civil Registry. It was in January. So actually we have now a new principal secretary. Our next plan is after this trip, we'll go back home and try to make an appointment and to present the finding to the new PS. Then from there, he will take action, maybe to call another meeting with high level, so to disseminate the result. Thank you.
Thank you so much. Sorry, please go ahead.
Yeah. Regarding Bangladesh, our study was conducted only in a union. Yeah, that is very small area. Very, very, very small area. This is the smallest administrative area of our country. So what we are doing now? We are duplicating this in 8 more unions. And we have already talked with the Ministry of Local Government and the Cabinet so that we can initiate this initiative and replicate the system across all the unions in Bangladesh. And I think this can also be helpful for all the LMICs, lower and middle income countries, to clear the backlogs, which is a great problem, not only for birth registration, but also for death registration. Thank you.
Thank you so much. I know there is a question from this table, then that table. Please go ahead.
Yes, my question is I'm Kennedy Otieno from CRVS Kenya. My question is to Dr. Richard. In your conclusion, you say that birth registration was delayed for the 5-year period because of young mothers under the age of 15 years. Is there a government intervention for the young mothers? Then my question to Kuma from Nepal. One of my findings was I'm doing a study on digitization, and one of my recommendations was that we fully move to digitalization. But you said in your recommendations that the respondents, they are not so much interested in digitalization. They want system simplification. Just a small clarification. Thank you.
Thank you for the question. Yes, there is a action plan that we have already started. In our recommendation, present the result to the director of NICR, then to try to call a meeting with other key stakeholders involved in CRVS activity like a UNFPA, so that to put them on board to try to solve this situation whereby the infant 15 years old is pregnant. That's what we found in our data, although it was just a 0.7%. So with the new step that the country is going to take, the new roadmap, putting everyone together, NGO, different ministry, I think we'll make it and try to solve this situation in the next future. Thank you.
Okay, in context of Nepal, online system means parents fill up the form, upload the documents, and they need to go with the original document to get the certificate in what registrar office. So if we change the verification process through the national ID, this will be minimized. So the registration and timeliness will be increased. This is the findings.
Thank you. Would you like to go? Thank you.
Thank you very much. My name is Alvina from Indonesia. I'm sorry, am I missing the presentation? My question is to Dr. Haider. So just to understand the broader context in Pakistan, are there any example that hospital that already notifying the birth or death to the civil registration office? And is there any mandate to support this initiative? And then is there any plan in your hospital to conduct the pilot regarding notifying the birth and death to the civil registration? Thank you.
Thank you very much, Alfina. Regarding this question, I would tell you that I'm talking about the two extremes of the system. One is the mainstream health system, like the provincial and the federal health departments and their facilities, and one is the parallel health system. Let's talk about first the mainstream health system. Yes, mainstream health system has adopted digitalization of the CRVS system. They have prepared their on all the provinces, almost all the provinces are prepared their gadgets. They prepared their mobile applications, and they are really chipping into the CRVS system. I would mention that at the federal level, there is a project which is going on, One Health, One ID, for all the hospitals, and they're linked together in the mainstream health system. What I'm my study was regarding, it was parallel health system, which is really not taking part in any activity of the CRVS. Even they are not notifying anything at the parallel health facility level. So I'm taking this one of the organization. Otherwise, I'm assuming other parallel health systems are also having a similar, because they are not obligated to provide these activities. They are just confined to do the healthcare system, their health services. So the main challenge for my my area of study is that to bring the health parallel health system into the main stream for the CRVS activities related initiatives. So this is really lagging behind, and we are now forcing that by the administrative note at least to have a first go and start of these activity initiated these activities. It will trickle down to all the facilities, and they will start doing the activities for the CRVS. So this is the first thing which I'm hoping, and it can be achieved in maybe in less than 6 months. So once top head is convinced and he gives an orders to all the facilities down there, they will obviously they will start doing these activities. So this is my nearest aim to after this study. Thank you.
Okay, thank you. Do you have any questions? Yeah, please go ahead.
More than a question, sort of curiosity to hear from all the panelists around digitization, because it has come up a few times and colleague also talked about it. So, I mean, we've also been doing a lot of research on digitization in the Asia Pacific, and we've found a lot of evidence that, without digitization, without safeguards, legal safeguards in terms of data protection, privacy, and redressal mechanisms, it could be dangerous as well. It could be data leaks, and also in terms of how you share data from one bureau to another. I think Mr. Sharma also talked about now using national ID, which is a digital ID system with birth registration. So my question to you, do you think does it really solve the issue of then hard to reach communities? Because they would, I think our evidence has shown the hard to reach communities would still be marginalized or not be included in the digital ID system. So I'm really curious to hear from all of you on this as well.
Okay. Yes. Yeah, marginalized community, those who do not have a documentation in Nepal, this is really difficult. So for those group need to another interventions like camp and other interventions. Digital ID will help in urban areas where those parents are digital literate, and they can use submit form and all those things. So it will be more better or will get results from urban area. As you said, in rural area it is difficult for the parents to submit form and all those things from the online systems.
Thank you for highlighting this very important aspect of the CRVS initiative. I'm assuming that you are referring towards the legal, legislation or legal, responsibility of the organizations. So let me tell you that this is a big challenge because of the fragmentation of the system. After the 18th constitutional amendment, all the provinces are having autonomy in the health system, health subjects. So they have to make their own legislative instruments. So this is a big challenge because previously we were able to make a federal legislation and they trickle down to all the provinces. They follow the same thing, but now this is not the case. So every other province has to come up with the same kind of legal instrument so that there is harmony, there is synchronization, there is data should talk to each other as you mentioned. So it's a challenge, and we are struggling it for 5 to 6 years. We are convincing stakeholders, especially at the provincial stakeholders and the federal stakeholders, who can come up with this solution, because different provinces has different modalities of going for this legal instrument. So we are struggling for it, and but slowly and gradually we are trying to convince from the federal level. We have made the technical support unit to support these kind of initiatives. So hopefully we are going to resolve these issues.
Thank you for the question. For us in Lesotho, we are trying to digitalize the system, but it is going well. But at the other end, we are facing some challenge because it is not legalized. It is not in the law. The law is still up to date. So those are one of the things that we need to solve, to legalize, so that it can digitalize, it can be in the law. That's one. Secondly, in terms of human resource, because there are some community village, they are very scattered, very far in the hard-to-reach places. So where we have put some CR officer, they are capturing the event when it's happening and send it to the next level. This one also is face challenge, as I've said earlier, in terms of contract, because they are working under, they are not permanent 2 years contract. This is some of the challenge that we are facing. So all of the challenge we are facing, we have put it as a recommendation, then submit to the high authority. And recently, Lesotho, we have conducted a CRVS assessment in 2019, and from 2020 to 2024, we have come up with a CRVS work plan. So last year, in 2025, we got a consultant who was being hired by UNICEF with the support from ECA to come and help us to review the work plan. So I can tell you that 80% of some of the recommendations that come from this research, the consultants also has a similar point, the same recommendation. So we hope that going forward, the government and together with some stakeholder will take that in consideration to try to put everyone on board and to solve the situation, to strengthen the system.
Thank you so much. Do you have any online questions? No, right?
No.
No. Okay, please go ahead.
All right, so thank you very much. My name is Bizo Tungwane. I'm from Ghana. I work with the National Statistical Office. So my question actually is a follow-up to your submission. Sorry, I missed your name, but okay, great. So with regards to the methodology that was used, you indicated that you visited households, right? You visited households and then you collected the data based on the households you visited. Particularly with regards to the death registration bit, I think the reference period you quoted was 3 years, right? 3 years. You asked the household if
Show the slide, please.
yeah, so on the death
Without-
registration.
This
Yes,
one?
Yes.
Yeah.
Yeah, this one.
This graph
Yeah.
shows
So actually, perhaps let me just move straight to the main issue. So I want to know how you dealt with individual member households. Did you have any experience with that, and particularly issues of relocation?
Oh, yeah. Got your point. Yeah. Particularly, we could address only those who are present, those who reside on this area.
Okay.
We couldn't address those who has migrated or those reside at any other area. Like some people in our area, they don't live in the Kumilla Gunaighar. Particularly, they live in Dhaka or even in the district level. We did three things, but we tried to address those. Particularly, we continued this for around 1 year. So we continued the intervention. Even still now, the intervention is continuing. Because as this was not paid something, we didn't need any money. We just used the existing system. So particularly, we didn't need any funding for that study, for that intervention, and still it is continuing. So whenever they come to home, sometimes our community people, those like the this is called member of the Union Parishad, the UP member. He informs that he knows that this person has come. He talks with him. Hey, have you anyone those who has died already in last 2 or 3 years? Has he or she registered? Has her or death registered? If that is not registered, that is registration. And the population size is very low. This is like 22,000 only. It's like only 2,000, around 5,000 household. So this is very a small intervention. And particularly, we focused only one thing, that we can improve with existing system without any external resources. Thank you.
Thank you.
Please go ahead.
Mine is a comment, especially to Samad. My name is Mose Job from East African Community Secretariat. I'm responsible for vital statistics and censuses. Mine is on the methodology used to determine the sample size. I know you used power method, which by default gives 385 as the sample size, regardless of the population size or the target population or households. So maybe when you go back, you may need to recheck on the methodology, whether that methodology was the most appropriate to determine the sample size that you visited in the field to collect the data, or you may need to check and review. Thank you. Just a comment.
Thank you.
Yeah.
So I'm Nicholas from SCAP, and I have a question for Nirmal. So first off, congratulations to all our speakers and for your very good presentations. And so we already had a lot of questions in the room, but and we already talked about some of the reasons about some of behind the urban paradox in Nepal. And Subhashri pointed out that well, in Bangladesh, in the case of Bangladesh, some rural regions had actually stronger systems, right? The system was stronger in rural regions and urban than the urban one. And from your results and from Q&A, it seems that in Nepal, it seems like heavy administrative procedures are one of the main factors for that paradox. And you talk about parents having to visit the registration offices multiple times in the urban context, not having the ability to submit online forms, or doing things like having to provide having to provide more official documents in the urban setting. So technology seems to be a key solution to kind of fix this paradox, but so does having less requirements. So according to you, what can the urban registration offices learn from the rural one in Nepal in order to strengthen overall completeness?
Nepal, rural is higher registration because of the social benefit. Most of the rural area provides government when child born, they get the benefit, incentive. So that for the benefit, rural areas social protection registration rate is higher. This is well known. For the urban area, maybe integration of national ID for the all peoples, all the parents, this might be verified from their own home or location. They not need to visit the ward office. In most of the during the discussion in qualitative focus group discussion and qualitative interview, they will register or they can get certificate from home. Might be increases.
Thank you. Thank you so much. Is there any other questions? We are almost, we have 8 minutes more. If you have no questions or questions, we can have discussion or else we can close the session. Okay. Yeah, I can understand. UNCC has a great canteen, by the way. Okay, so thank you so much. I would like to thank all the speakers, and let's keep this conversation going. I encourage to exchange numbers, contact information, so that you will be in touch. Let's give everyone a last round of applause and enjoy the rest of the CRVS Research Forum. Thank you, everyone.